Hello, and welcome to today's seminar. In the spirit of reconciliation, we'd like to begin by acknowledging the traditional owners of the various lands we are coming together on. We recognise their continuing connection to land, sea, and the community. We pay our respects to their elders past and present, for they hold the stories, traditions, the culture, and hope for their people. My name is Chani Hodgetts. I'm a clinical content producer and with a background in haematology nursing, along with my colleagues Linda Thompson, a blood cancer support coordinator and haematology nurse, and Linda Saunders, our National Education and Support Group lead with a background in cancer social work, will be running today's seminar. Autologous stem cell transplants are a treatment option for people who need to have high doses of chemotherapy to cure or manage their disease. They use healthy blood stem cells from your own body to replace the stem cells damaged by high dose chemotherapy. The aim is to treat the blood cancer with high dose chemotherapy and then restore the body's ability to make normal blood cells with already collected stem cells. This is a complex and time consuming process. In this series of 3 seminars, we aim to explain and demystify the process from the decision to have a transplant through to recovery and the months following. At the end of each session, there will be an opportunity for a more in-depth discussion with the presenter and a person who has had an autologous stem cell transplant. In this first session, we look at the decision-making process, stem cell collection, and the physical, mental, and practical considerations in preparation for a transplant. Before we continue, just a few practical reminders. You can add questions and comments in the chat. These will be collated and addressed in the Q&A after the presentation. We have shared the pre-submitted questions with our guest speakers. Please understand we're unable to answer specific medical or highly personal questions. For the best experience, please have your view on speaker view. Keep your cameras off and microphones on mute. And just a reminder that this session is being recorded. Firstly, I'd like to introduce Bernadette. Bernadette was diagnosed with myeloma in 2018. She did not need treatment initially, but had regular monitoring and weekly injections. At the time, she was working part-time for the Department of Education as a speech pathologist in primary schools. She's been very healthy. She's married with 3 children and now has 6 grandchildren. At the time of her diagnosis, she had been looking forward to retirement and had just bought a caravan in preparation for travelling. She started treatment in April 2020 and had an autologous stem cell transplant that year. That was the year of COVID, so she had to contend with many issues over and above actual treatment related to lockdowns. Let's hear a little bit more about Bernadette's story.
Good morning. When I reflected on what was important to me as I prepared for my stem cell transplant, I think information and support were the 2 things that were really important. I started my treatment 18 months after my diagnosis with myeloma, and at that time I was provided with a lot of information, some verbal, some written. My haematologist outlined the process, and I started 16 weeks of weekly chemo leading up to an autologous stem cell transplant. He has walked me through every step of the process: chemo, transplant, ongoing treatment, and post-transplant immunisation program. He gave me a lot of information at each of our visits. However, in retrospect, there was a lot that I didn't take in, some that I didn't remember, and many things that I forgot to ask. Initially, my husband came to the appointments with me until COVID meant that couldn't happen anymore, and that was great in filling in some of the gaps. After every appointment, I would feed back to my siblings and my children, and they invariably had questions that I didn't have the answers for. But that was great because it prompted the questions for the next visit, and I made sure I wrote those down in my book to ask the doctor next time. All of my siblings and most of my children live away from me, so having technology to provide that instant communication easily was wonderful. I felt quite comfortable during the treatment phase because there was a definite plan. I had constant monitoring and wonderful support from the nurses in the chemo unit. Luckily, I didn't have any significant adverse reactions to the chemo, although I did feel quite fatigued for a few days after each session. My main concern then and now is avoiding infection. The cancer coordinator at the hospital visited me regularly, and she was great at reinforcing the information I'd been given, making sure that I understood what was happening, and also broaching some important issues, such as making a will, appointing an enduring power of attorney, and writing a advanced health directive. We had done the wills and the power of attorney, but it was great to be reminded about the advanced health directive. She was also able to tell me that I was able to access income protection payments through my superannuation policy. I didn't know this, and that was wonderful because once I had exhausted my sick leave, I was able to access the income protection program, which meant that I didn't have to make serious decisions about my future work situation while I was in the middle of my treatment. As my treatment was in the COVID year, for the 3 weeks of the transplant, I was not able to have visitors, including my husband. Constant phone calls from our family and friends was so important to my husband. I was quite focused on all that was happening on a daily basis in the hospital, but my poor husband was home alone, anxious about what was happening, unsure of what the ultimate outcome was going to be for me, and powerless to do anything. I can't overstate the importance of that constant contact and support for him. I was well prepared for the stem cell transplant. Despite the lockdown, my husband was able to come to the education session with me because the team considered it vitally important that we both understood what the process was and what to expect during that time. I found the harvest days quite exhausting. Having to sit perfectly still was a real challenge for me. The nurse sat with me the whole day, encouraging and distracting me. She was wonderful. The period in hospital for the actual transplant was exactly as I'd been told it would be. Lots of tests, quite a bit of boring time when nothing was happening, then the transplant, and then immunity hitting rock bottom a few days later and feeling pretty awful for a few days. I'd been prepared for that, so I wasn't surprised. Sadly, when I went home after 3 weeks, I developed a fever 24 hours later and was readmitted to hospital for another week. Happily, the rest of the recovery was not so dramatic. 3 years later, I'm pleased to say that all is going well. I still take medication and injections, but now I'm on a 10 weekly blood test and doctor's appointments to monitor my progress. Thank you.
Thank you, Bernadette, for an insightful personal experience there. You highlighted some very important aspects of the transplant preparation, and I love that you touched on the boredom there. That's a common thing experienced by lots of people during that stem cell collection. I particularly like that you discussed about getting your affairs in order. Thank you so much for that. So Bernadette is with us today and will be joining us in the Q&A, so there will be an opportunity to hear more from her and ask her questions. So now I'd like to introduce Nectaria Matsamakis. Nectaria completed her Bachelor of Nursing at La Trobe University in 2005, then followed by further study in cancer and palliative care nursing, specialising in haematology. She's worked in haematology at Austin Health and the Olivia Newton-John Cancer and Wellness Centre since 2006. Nectaria was a clinical nurse specialist and an associate nurse unit manager on the haematology ward for several years. She then moved into the apheresis unit, conducting stem cell collections, and was part of the nurse-led PICC insertion team. Nectaria has been a bone marrow transplant nurse consultant since 2013. She is currently the Autologous Bone Marrow Transplant Nurse Consultant at the Olivia Newton-John Cancer and Wellness Centre and has been in this role permanently since 2018. Nectaria is responsible for coordinating and educating patients regarding their stem cell collections and transplants, and she has cared for patients at every aspect of the transplant process. Thank you, Nectaria. Over to you.
Thanks so much. I'll just share my screen. So just going into the session outline, thanks for that nice introduction. So my name is Nectaria and I'm the Autologous Transplant Nurse Coordinator at the Olivia Newton-John Cancer Centre. And just moving into The session outline today will be looking at the indications for transplant, what makes you a transplant eligible patient, decision making and gathering information, as Bernadette highlighted the importance of that. We'll touch on fertility considerations for those who are of childbirthing age. We'll look at the stem cell collection process. We'll look at some practical issues, including work, support, carers, relocating costs, and getting your affairs in order. And while you're awaiting transplant, what tests and what to organise and what to bring to hospital. And just wanted to highlight that throughout this session, you know, throughout all of Australia and different health services, processes, protocols and guidelines will vary. So just keep that in mind as well. So why is an autologous stem cell transplant needed? The purpose of it, as it was already been touched on, is to restore the body's ability to make normal blood cells after high-dose chemotherapy. So the high-dose chemotherapy will destroy the healthy cells in the bone marrow, and then the cells rescue or regenerate the bone marrow to make it all healthy again, so you recover much quicker. It helps to maintain remission or control the disease. When we're talking about cure, usually we're looking at lymphoma patients. And as it's already been said, it's all about the chemotherapy, and the stem cells are just so that you can recover much quicker. Without stem cells, you'd probably be in hospital for 3 to 6 months waiting for your bone marrow to recover. But by giving you these stem cells, it means that you can recover in 2 to 3 weeks. Obviously, the recovery after that can be a bit of a process, but that initial recovery can be much quicker and much safer for patients. So looking at myeloma patients, it's something that's offered as an upfront treatment, and that's the standard of care at the moment. And for lymphoma patients, it's usually at relapse, and in some types of lymphoma, we may consider it as an initial treatment in rare types of lymphoma. So the reasons for transplant, as we can see, the patients that are mostly autografted are myeloma patients. Followed by lymphoma patients. And as I said, Hodgkin's lymphoma patients. So, and then the non-Hodgkin's lymphoma patients, the most common type would be your diffused B-cell lymphoma. Again, that's usually done at relapse, but there are some other rare types of lymphoma, as I said, that we might consider doing it as an upfront option. There's a common question that people ask, what's the difference between, I just wanted to touch base on this, what's the difference between an autograft and allogeneic transplant? Just very simply, with an autograft, we're collecting patients' own stem cells in advance when the disease is under control or in remission, and we store them, and then we return them to the bloodstream at a later date after that high-dose chemotherapy. Whereas an allogeneic transplant is a lot more complicated, and the recovery is a lot more, takes much longer for patients to recover from that. And there is a lot more complications, and that's when we use cells that are donated from another person altogether. So just looking at myeloma and lymphoma just a bit more separately. So with myeloma transplant patients, it's, as I've said, it's performed at induction treatment to give high-dose chemotherapy. For myeloma patients, they're always almost certainly given a drug, the chemotherapy called melphalan, to destroy the remaining cells or to control the disease for as long as possible. There's increased likelihood of remission or plateau and a better quality of life after a transplant to keep you off some active treatment. You need to be fit enough to withstand the intensive chemotherapy, which we'll touch on in the next few slides. And just remembering that myeloma is very individual. So it's very important not to compare what the next person, what their treatment pathway looked like, because for everyone it's going to vary because there's different characteristics of a myeloma patient for every person. And there are some circumstances that with myeloma patients, they may be offered 2 transplants up front, where we call that a tandem autograft, or we may do 2 transplants 3 months apart, but only in certain circumstances. With lymphoma patients, again, usually performed, as I've said, at second-line chemotherapy treatment at relapse. We occasionally do it up front. There are various types of chemotherapy that we'll use during the transplant. Again, that's dependent on the type of lymphoma that you have. And we are trying to achieve remission, and we need to see that with the lymphoma that you are responding. So you need to be what we would call chemosensitive to continue with the transplant, because if the chemotherapy isn't working at relapse, then the transplant's not going to work in this particular case. So we are aiming for cure or to achieve a durable remission. Again, you need to be fit enough to withstand the chemotherapy, and as always, it's always going to be very individual to each person. So who is fit to proceed to a transplant, who is transplant eligible, it is really based on your fitness. It's not solely upon age. Generally, most patients, we sort of cut it off at 70, but it's not a, if you're 71 or 72, it's not a definite no. It's really an individual decision that's made with the medical team, and you may need to do some extra tests if you're at the higher end of that range, just to make sure that you are safe to proceed with this high-dose chemotherapy treatment and the risks that follow with that. And as I said, you might do some of those tests that we might not do until later in the process. You might get asked to do them before we even consider doing the stem cell collection to ensure that you are going to be fit enough to continue. So in terms of the decision-making process, making a decision to proceed to the transplant can be very stressful. So at the end of the day, everything that we do, these are the recommendations of the doctors, but it's important to feel that you have enough information to make an informed decision and not feel rushed. And that's where the use of, the doctors and the nurses and asking all the questions you need is really important. Make lists of questions before your clinic appointments. As Bernadette mentioned in her talk, she talked about how she'd go away and she'd forget to answer questions. So every time you see the doctors or the nurses, write down those really important questions that you have to ask. Bring a family member or friend with you to the clinic appointment, not just for support, which we'll talk about support people a bit later, but also as another set of ears, because again, it's very overwhelming listening to all this information, and that's completely normal. And I suppose our job as a medical and nursing team is to make this process as normal as possible for you and to answer all your questions at any point in time. So the treating doctor will spend time discussing with you and your family what is the best option for you, that you must be fit to proceed with a transplant. And as I've said, everyone is different. The stem cell transplant may not be the best option, but best way to treat you, again, depending on age, other illnesses that you may have. So other approaches, just as chemotherapy alone, may be a better option for some people. And the best decision that will be made, not just that what you think is the best decision, but the medical team will make what the best decision is for you to make sure it's the safest option for you as well. I'll just briefly touch on fertility consideration, because sometimes patients are still of childbearing age when they're diagnosed. Ideally, this should be sorted when you're first diagnosed. It's not something that should be really considered just before you're admitted to transplant. For females, it's a little bit trickier because the process of collecting your eggs can be a lengthy process. It takes a month. So sometimes there's not the time to facilitate that. Obviously, if there is time, we absolutely will, but more often than not, there isn't enough time to do that. There is a process where they can collect the ovarian tissue directly and store that. But most commonly, the thing that we use the most is probably the subcutaneous injection called Zoladex injection, which what they do is it kind of switches off the ovaries and helps to preserve them while we're having active treatment. For males, it's a lot easier. We can just deposit their sperm in a container and it's frozen off. And obviously, again, there's an option for couples for embryo storage, but again, that's a lengthy process because the female will need to collect this and store collect the eggs, and that's a lengthy process, as I mentioned. So just looking at the myeloma transplant timeline, most patients in this day and age at the moment, obviously it's a never-changing world, but currently most patients will have something called VRD treatment when they're newly diagnosed. You can have a number of cycles, may vary between each transplant centre. And as we can see here, most cycles, again, it does vary, but either 21 or 28-day cycles. And then there's a stem cell collection, and then you usually continue on with more treatment and then the transplant. The reason we do it this way, because before VRD was introduced, we used to give all the chemotherapy, then the stem cell collection, and then straight to autograft fairly quickly afterwards. The reason we do it this way now is because the lenalidomide, which is the Revlimid, which is a fairly new drug in Australia, or the availability of it in Australia is fairly new, is great for the myeloma, but unfortunately it is toxic to the stem cells. So that means that we need to collect these stem cells a bit earlier. And the aim is to collect your stem cells after you've had about 6 weeks of the lenalidomide. So with a 21-day cycle, when you're having it every 2 weeks and having 1 week off, that's why we collect up to 3 cycles. And if you're having a 28-day cycle where you're having 3 weeks of the lenalidomide and a week off, that's why it's after 2 cycles. And just a lymphoma timeline, looking at an upfront transplant, it's whatever chemotherapy that you're on at the time. most commonly, I'll just give the example of R-CHOP. We may collect you after anywhere from the 3rd to the 6th cycle, and then the stem cells will be frozen away. We'll talk about the process of stem cell collection shortly. You'll have your stem cells and then the transplant. Whereas with relapsed transplant, we will give you some chemotherapy. We usually assess whether you're responding. Again, this varies between each health service and what they prefer to do. And if you're responding to that PET, we continue on with the 2nd cycle and then proceed with a stem cell collection. Then following that, you'll have a more disease reassessment with a PET scan. And if you continue to be in remission or responding, then we proceed to autograft. Again, as I mentioned earlier, if you're not responding to the chemotherapy, there's no, the transplant's not going to be the most effective option for you, because the chemotherapy is, the transplant's all about the chemotherapy and further consolidating that response. So if the chemotherapy is not working in the first instance, it's not going to work later with a high dose chemotherapy. So just looking at what are stem cells. So stem cells exist in the bone marrow and have the ability to divide and develop into 3 main types of cells found in the blood. You have red blood cells, which carry oxygen from the lungs to the entire body. You have white blood cells, which fight infection by combating bacteria and viruses, noting that neutrophils are the most common type of white cell, and they're the first line of defense. Then you have your platelets, which form clots and help control bleeding from injuries. It is the unique ability of the stem cells to divide into blood cells and to be collected safely that make autograft a stem cell transplant option, as we talked about earlier, that your recovery is 2 to 3 weeks rather than 3 to 6 months. This is a very basic diagram here. The extended version is a lot longer, but just to gives you an idea that what happens is a stem cell can divide and make your bone marrow all healthy again. So if there's no stem cells, if we can't collect the stem cells, which happens in a very small amount of patients, then unfortunately we won't be able to continue with the autograft transplant. So how do we collect stem cells? So stem cells are collected from the peripheral blood in your veins. There's no big needles in your hips or anything like that. The process is similar to a blood donation. We need to stimulate the overproduction of your stem cells in the bone marrow so they can spill out into your bloodstream. You need to formally consent to the stem cell collection with your transplant doctor as well, so they'll talk to you about that whole process. And usually there's an assessment done by the nurses who collect the stem cells. And just for anyone who's wondering, apheresis actually means to remove. So we're removing the stem cells, and that's why that's the unit that collects the stem cells. So when you're being considered or being worked up for a stem cell collection, we'll do some blood tests, mainly to look at some blood-borne viruses that may need to be treated if currently active. But the main reason we check for blood-borne viruses when someone is having a stem cell transplant for an autograft is really to determine the safety storage of the cells. Because if you've been exposed to hepatitis B and it's currently been treated in the appropriate medication, there's no real risk to yourself because the cells are just being reinfused into you. We also assess your veins to see if we can collect your stem cells with just normal needles in your arms, or sometimes we'll need to put a venous catheter in the neck called a vas cath, which I've got some pictures in the next couple of slides. So a stem cell collection, before stem cell collection, your bone marrow needs to be stimulated. So when I talked about that overproduction of stem cells, that process is called mobilization to help release the stem cells into your bloodstream. It is more common these days to collect the stem cells from the bloodstream, as I talked about earlier. And there's 2 main methods that we use. There's the GCSF injections only, which or we use chemotherapy and GCSF injections. In terms of the stem cell collection occurs in apheresis with a centrifuge machine. Again, in the next few slides, I will show you some pictures. It can take up to 3 days to collect the stem cells, and you're never on the machine for more than 5 hours because some of the side effects of that, which again, I'll discuss in the next few slides. So just looking at myeloma more closely, it's more commonly collected with GCSF alone injections and usually given for 4 nights, and then we aim to collect on the 5th day. As mentioned before, sometimes patients are, with myeloma, we always collect for at least 2 transplants, sometimes 3, depending on individual circumstances, because you can require transplants in the future if they've been successful and it's kept you off treatment for several years. And with lymphoma, more commonly collected with GCSF and whatever chemotherapy you're currently on, it's seen to be more successful that way, and is a more aggressive way to collect stem cells because the chemotherapy used for lymphoma is more toxic to the bone marrow in general. So therefore your reserve of stem cells may be lower. So then by collecting your stem cells with whatever chemotherapy you're on, it's a more aggressive way to stimulate the production of the stem cells as well. So just looking at GCSF injections a bit more closely, they are a glycoprotein that stimulate the bone marrow to produce stem cells and release them into the bloodstream. The side effects of these injections are bone pain, headache, tiredness, just feeling tired and off, and feeling you might have a low-grade fever as well, never above 38 degrees though, so maybe up to 37.5, and like you've got a bit of a viral illness. The bone pain is probably the most common thing, because you have to think there's an overproduction of stem cells wherever you've got lots of bone marrow. So across your hips, across your shoulders, sometimes even your sternum, which can be a little bit concerning to patients. It usually feels like a bit of a throbbing pain, but I always tell my patients, if you ever are worried that it's chest pain related to your heart, you need to seek medical attention at all times. And usually Panadol can help relieve that pain. Occasionally, you may need some stronger medication like Endone or Oxynorm. That's a fast-release morphine tablet. And then the question is, if all of this is failing, how else can we get the stem cells collected? There is a drug called plerixafor, which up until recently, it used to cost $6,000 to $7,000 a vial. Thankfully, that cost has decreased, and it's all covered by the government, which is fantastic. It's a drug that needs to be given at a certain time at night, so that when we're trying to collect at a certain time in the morning. And there's strict criteria of whether you're eligible for plerixafor or not. But basically, I describe it as the GCSF injections help to overgrow the stem cells, and the plerixafor helps to cut the receptor, which is the CXCR4-SDF1A interaction, cuts that off and helps to release them into the bloodstream, so where they can be collected. Just going back to the venous access, so in most centres, what they'll do is if your veins are good enough, that's great, and we'll put 2 needles in your arm. Usually one's a much bigger needle called a fistula needle, which has a metal end, which means you won't be able to bend that arm during the collection. And the other one's just a normal cannula, so we can, as we're withdrawing blood and returning on the other side. And then the other type of lines that we may use is a vascath, which is just here, which we can put in fairly quickly in the neck. And sometimes, generally, a permacath may be used for lymphoma patients, and may be used to give all their treatment once they relapse. And those lines are actually wide enough that we can collect. And just really quickly, during a treatment, you may have a PICC line or a Hickman line, but unfortunately those lines are not wide enough to withstand the pressures of the collection, because we are processing blood at 50 mils per minute. So it's happening all really quickly. So the pressures are too high to collect on those narrow lines. So just looking at stem cell collection, so as you can see here, you'll be sitting in a big comfy chair, just noting that these are common stem cell collection machines, but they may vary from hospital to hospital. And as you can see, there's one line that removes the blood, and then the other line returning the blood that we don't need. And what's happening is the blood's going maybe 200 or 300 mils at a time, is spinning in the machine. It's separating all the cells, and the stem cells are going back into the bag. And as I said, then the rest is going back to the patient. And this picture here on the left is what we can see when we look inside the machine. So you can see all the different layers that are separating in the machine. On the top, we've got the lighter cells, which are the plasma cells and the platelets. At the very bottom, we have the heavier cells, which are the red blood cells and the white cells. And in the middle here, you can see a very fine grey line, and that's called the buffy coat. That's where all the stem cells live, and that's what we're aiming to collect in the bag here on the right, where you can see there's a bit of blood in the middle there. And we'll talk about some of the side effects, but here there's calcium being administered, because sometimes when we're having the stem cells collected, your calcium can drop, but we'll talk about the side effects, I think, in the next slide or two. So the side effects of your stem cells, and as I've said, because when your blood leaves your body, it wants to clot naturally. So when we're doing the stem cell collection, we want things to be running nice and smoothly as the cells are all separating. And we don't want any clots in the machine. So you've got your blood is automatically mixed with medication called citrate. And it's not harmful, but as you're getting back the blood that you don't need, you're getting part of that citrate back. And we know that citrate, it likes to leach on and binds to the calcium and other salts in your body like potassium and magnesium, but in particular the calcium. And because we know this, we actually give you calcium as a preventative before we start the procedure, and sometimes we'll opt to give it to you intravenously during the procedure. So it's a very well-controlled environment where the calcium levels are checked regularly to make sure that everything's okay. But if you are to experience symptoms of low calcium, it usually starts with a metallic taste in your mouth, some tingling and numbness in the face and jaw area, and that's really how it usually starts. There's tingling in your fingers and toes. You may have cramps, and in severe cases, seizures, although I've never seen that because, again, it's a very controlled environment. So as soon as you have a metallic taste or tingling in your face and jaw, the nurse may slow down the procedure and give you calcium, and then usually the response is fairly quick, and all those symptoms usually resolve fairly quickly. In terms of hypovolemic shock and cardiac arrhythmias, because we've got all these fluid shifts, just to give you a broad indication, we can, in your entire body, you have 6 or 7 litres of blood, and we may process all of that blood up to 3 times during a stem cell collection in each day that you're there. But you've only got maybe 200 or 300 mils in the machine at any one time. So you don't have a lot of your blood outside of your body during the collection. But because of all the fluid shifts, sometimes some patients are a little bit more sensitive and it might drop your blood pressure a little bit. You might need a bolus of some fluid, or your heart might do some fuzzy rhythms. But again, you're very well monitored and looked after very closely, and you know, those symptoms are dealt with very promptly. And something else that's probably mentioned, one of the other side effects is boredom, because it's like you're sitting in a long haul flight for hours at a time, especially towards the end when you're due to come off in the next hour or half an hour. It can seem like it's taking an eternity, which what patients usually describe it as. Support and the transplant. So the autologous stem cell transplant is deemed to be the best option for you. It is important to have good support around you. You will need support during the stem cell collection, transplant, and once you're discharged from hospital. But just winding that back, it's important to remember too that if you need proper counselling when you're diagnosed or going into your transplant, it's important to try and get on top of that as early as you can, not thinking to yourself, I'm going to do it after my transplant, because although we're looking after your body physically, we also need you to be in a good mental space going into the transplant as well. So it's important, I would ask, the quickest way to get some access to good counselling is getting a treating doctor or nurse with a referral, or going to the GP to get a mental health plan. The Leukemia Foundation has some great services as well to access counselling. The Cancer Council does as well, and the hospital that you're being cared for may offer counselling through social work and psychology as well. So just looking at some practical issues in terms of work, you may have continued to work during your treatment, but you will not be able to work during the transplant for a period of time. So myeloma patients, especially because VRD is fairly well tolerated, you'll find that you might be working throughout all of your treatment, and then obviously then you have the transplant admission, and then you might not be able to go back to work usually for 3 to 6 months to recover. But everyone's recovery is individual. You need to plan your absence from work as well and let your employer know. If you're needing to return to work earlier, and if that's what you want to do, you know, your transplant nurse and doctor, we're here to help facilitate that. You know, if you're able to work from home during shorter days, and helping your workplace with a return to work program that best suits you. And again, it's all individual with patients. I've had patients go back after 4 weeks. I've had patients who've needed 6 to 8 months to feel that they can do, and also it also depends what kind of work you do as well, if it was more physical or if you're able to do things from home or not. And the biggest factor in terms of returning to work is, you know, the nausea and the diarrhea. Those will all settle fairly quickly after discharge, but the thing that takes the longest to recover from is the fatigue. So just looking at support again, in terms of a support person, if there's lots of options, it's important to try and nominate a primary support person while preparing for transplant. This person will need to take carer's leave, but mostly required around the stem cell collection, the discharge and post-discharge. They don't necessarily need to take off the entire time that you're in hospital. It's important to plan this early. There are some programs in certain services where part of your transplant might be an outpatient, so that support person will need to be with you 24 hours a day for the 5, 6, 7 days that you're an outpatient, if that's what's offered to you. So it's important to have those conversations early with whoever might be your support person, which your husband, wife, friend, relative, whoever that is. If you have a large family, especially, it could be helpful to start designating a person to be the communicator. An example of this would be if you have 5 children and they all want to know everything all at once, it might be a good idea to nominate the one person to be the direct person that you give most of that information, because it might be exhausting giving that to all 5 people, so that can be the primary person to receive all that information. Involve your support person and family by giving them regular updates leading up to the transplant as well, especially young children, so they can understand that you're going to be away for a time period of being in hospital and what that recovery looks like for you, that you might, that mum or dad might not feel like playing for the first few weeks of being home, and getting them prepared for that, so they're aware and they can set their expectations, and that you're going to be in hospital. And it's important to set those expectations, not just with the children, but with everyone, with your family and support people that are around you. Ask your treating team to provide education to your family as well. I often, although I touched on it's important to have a designated communicator, sometimes it is also important, there might be a couple of children that you need to do some education to, and most transplant centres, your nurse coordinator is usually happy to facilitate that, or whether we can organise a group session so everyone can have that education and feel supported in that. That could be an option too. In terms of when you go home and your support, it's not expected that you're going to be needed to be showered and dressed, but that person that's around, or the people, there might be a roster of people doing that for you. In the first couple of weeks that you're home, they just need to be sure that you're eating and drinking and not spending all your time in bed, because that will stunt your recovery, because they need to motivate you to be up and about and start doing things. I just wanted to also touch on, what happens if you don't have a support person, and your certain circumstances will be reviewed by your medical team. And if we think it's still the best option for you, we'll try and support as best we can. And you may mean that you are in hospital for that little bit longer to make sure that you're safe to be discharged, as opposed to someone going home a little bit earlier where they've got that support at home. So in terms of relocating costs, if you are in regional areas, you will likely need to stay within 30 minutes of the hospital for 1 to 2 weeks after transplant to ensure you're managing before heading home. Carer is to stay with you if you're staying at some local accommodation that's being organised for you. There's assistance offered by the Leukemia Foundation. You can get in touch with your designated blood cancer support coordinator or accommodation coordinator. They're great at helping with that. Travel and accommodation subsidies may vary between states, and I've listed here, there's different schemes. Generally, I'm only going by in Victoria because that's where I'm based, but usually you're given $60 per night, and then that's through these travel and accommodation schemes that are given through the government. But then there's also the Leukemia Foundation, who can give you additional support. So the subsidy in the end can be quite substantial, so don't disclaim that if you need help with that. Also making sure that you're linked in with a social work for assistance, and also they can help with financial support and counselling as well. So in terms of getting your affairs in order, which Bernadette did touch on, it's important that you appoint a medical treatment decision maker. You can plead a will, although to be honest, we all should be doing that. So it's not something that you should just be doing because you're having a transplant. Advanced health directive, and appointing a medical power of attorney, enduring power of attorney. It's recommended to ensure your financial affairs are sorted with regards to mortgage, income during admission and recovery. Again, Bernadette talked about how that was really important to her, that she was able to get income protection payments so that she didn't have to make a decision about her workplace until after she finished her transplant process. Give your workplace notice that you'll need an extended period of leave, so they're aware as well. But if you're self-employed, making plans for you to be away from work and allow yourself to recover. Preparing your family for your admission and recovery so they know what to expect, especially children, as we talked about. So it's really important. They're really good with, I think, if you're really having honest conversations, so that they can set the expectations of mum or dad being away, or nana and granddad being away, and things like that. Involve your support person network in the planning process and education, so they're aware of what's happening, so they're not left in the dark. And allocate chores around the house and the other family responsibilities. So if you've got pets, making sure that they've got places to go and what's happening with them, and all those sorts of things. Awaiting transplant, so just looking more closely at some workup tests that might be conducted either prior to stem cell collection, but absolutely before your transplant. These include scans. Obviously, with lymphoma patients, they'll be having regular PET scans, but also myeloma patients might need to have some scans as well. Blood tests to look at your kidney and liver function, but also more importantly with myeloma patients, looking at where your myeloma markers are just before transplant, so then we can assess the response after transplant. Heart tests and lung tests, again, we're just checking that everything is healthy before going into the transplant and making sure we're making the right decision about the chemotherapy we'll be giving you as well. We also want to know that you're going to be able to withstand if you get an infection and sepsis, because these heart and lung tests give us a lot of information about that and how you'll be able to cope with that. Doing a dental review, aiming for that to be about 6 months before the admission. The reason for that is we're trying to minimize infection. So if you've got broken teeth or infected teeth, going into the transplant with poor dental health is just a site of infection, and we want to eliminate that as much as possible. And obviously, if you're having problems financially, flagging those things early on with your transplant team so that we can get onto it, whether we need to make other referrals or arrangements to help you with that, because dentists can be quite expensive, and we understand that. Any further tests that the transplant doctor thinks might be important, if your liver function is not great, we might send you for some more tests. If your heart or your lungs aren't, they're okay, but borderline, we might send you off to see some specialist doctors, because they might put you on some medication that will optimize your heart and lung function before the transplant to make sure that you get through it really well, okay? And just practicalities of transplant, what to bring to hospital. So in terms of toiletries, I always tell my patients just to bring a soft toothbrush and toothpaste, shampoo, body wash. Ideally, some soap-free is preferred, just because perfumes and things can aggravate the skin, especially during the transplant process. Your skin is generally a little bit more sensitive, and chemotherapy in general will cause that as well. Mouthwash will be provided, but if you do want to bring your own mouthwash, don't bring anything with alcohol in it, because that will be more drying, especially if you end up with some mouth ulcers. That will just worsen the mouth ulcers. You can bring soft toilet paper and baby wipes as well for comfort, or you can see how you go. And if you do get lots of diarrhea and your bum's getting a bit sore, you can always bring those in as well. And in terms of clothing, just pajamas and comfortable clothing. You don't need to bring all your belongings. If you have that support team that can, take things home and bring washed clothes for you, clean clothes for you. Sometimes there's facilities available to wash your clothes. But also, if you're feeling pretty average and you've been having diarrhea and you just, especially that week in the middle where you're feeling pretty miserable, it's very common for patients just to use a hospital gown or hospital pajamas as well, just to get you through that tricky few days in the middle. You can bring your own pillow and blanket for some extra comfort. There's no rules around that you can't do that. You can certainly bring some photos for motivation to get you through those few weeks, or any special belongings. There is a lot of downtime, so it's not feeling horrible and wanting to sleep all day. So bringing books and laptop and iPads or some activities that to help pass some time. Patients, I don't know many patients that like hospital food, so you can absolutely bring some of your own snacks, especially if you feel like a midnight snack and there's certain chips or drinks or something that you prefer. And family can also bring in food for you as well, but obviously it needs to be freshly prepared and stored appropriately to make sure there's no risk of infection. And this is, whether it's not something to bring, but I always mention that I've had patients who are like, oh no, I don't like art and music therapy, but the ones that wouldn't normally be inclined to do it or would think that they wouldn't enjoy it, I've found have enjoyed it the most, and it's helped them get through especially their inpatient stay. So I do recommend that. That's the end of my talk, and we'll move on to the questions or whatever's next.
Thank you so much, Nectaria. That was some amazing amount of information. I'm sure that's been very valuable to most people. I loved the fact that you have really highlighted about the decision-making process around the autologous transplants and just the process of the stem cell collection and all of those practical issues to consider. So thanks again for your informative presentation. So that draws our presentation part of the seminar to a close, and I would like to thank Bernadette and Nectaria for sharing their time and expertise with us today,